I'm a chemist, but I'm also an exercise physiologist. So that second has more to do with my current job, and that's I'm from Berkelmans. And I'm going to tell you a few things about the practicality of electrostimulation and the things you can encounter with the spinal injured and trying to let them cycle. So, first, why fast cycling? Well, I want to tell you a few things that maybe you didn't know, because there's a lot of things you probably already know, more muscle mass, more cardiovascular fitness, etc. But a lot of people don't know that the life expectancy of people with a spinal cord injury is much lower than with able-bodied. And the reason that's relatively unknown is that in Europe we don't have very good statistics on this. In America they have a system where 30,000 people with a spinal cord injury are in it, and they started already in 1974, so it's measured in the same way as we would measure the life expectancy of able-bodied, so it's the best way to do it. And yeah, if you look at the life expectancy of an American of 40 years old, he has another 39.3 years to live on average. But if you go to a paraplegic, you already lose 11 years. With C5, C8, another 4 years. And if you're ventilator dependent, it's even worse. And these are people that are 1 year post-injury. So, out of hospital. Well, in this case, not even all of them out of hospital. And these figures can also be seen in less extended research, seen in a study in Australia and Norway, for example. And these are highly developed countries with a very good care system. Well, there are several problems, also pulmonary things, so coughing is a big problem. But one of the other things, which is underestimated, is the lack of exercise. Because as an able-bodied, you need to have enough exercise. We're telling our the inhabitants of the Netherlands, you should exercise more. Well, I think that's in all the countries. People are told to exercise more. But if you have a spinal cord injury, it's not that easy. And there's another, this is more systemic reason, general reason, but there's another big issue. And the reason that the slide is empty, because I'm going to show you some pressure source, and not everybody likes to see horrible pictures. So if you don't like to see it, just look the other way for a second. Pressure sources are a big, big problem. This on the heel, this on the heel, this on the butt. You can imagine if you have this on your butt, you have a problem. This can be life-threatening. Why are these things occur? You can watch all again. Why does it occur? Because there's not much blood perfusion, and now all the able bodies are sitting on a nice piece of meat, a nice cushion, a nice beef. But if you're spinal injured and you don't use this muscle, it's getting very weak and vulnerable, and the cushion is getting smaller, softer, and the blood vessels are not only smaller, but also more likely to be blocked. And if it's blocked, then you can get these kind of pressure sores. It's one of the main reasons, deformation of the muscles. Another thing is, if you have some wound, there's a lot of blood going through it. In our case, in the able-bodied, and the immune system has a nice system to get rid of bacteria and all that kind of stuff. But if the blood perfusion is bad and the immune system is low, then the bacteria can win. And then everything gets much worse. Now another study that's not so unknown, and that's a very very interesting thing. It's already an old study, 1992. It was already known that electrical stimulation cycling can help in psychological way. So it can make people feel better. But well, there were people that said, well, but that's because it gives hope, they see the legs moving again, etc., etc. But the twist showed that actually the beta endorphin hormone was almost tripled. And these are values in the morning and in the evening. So that's very interesting because beta endorphin is what's sometimes called the happiness hormone. And it gives a big effect on your mental health, your well-being. So this correlation is very interesting. So you can better be happy and in a wheelchair than an able-bodied and unhappy. So this is, I think, one of the most underestimated things because we all look at muscles and we look at blood perfusion and all of that stuff. Now something about injury level and FES cycling. It's Ken already mentioned a few times. First of all, you have to know the 7 vertebrae, 12 thoracal, 5 lumbar, 1 sacral. It's important to know that these are 7 vertebrae, but you have C1 to C8 because the nerve is coming, it's a counter nerve, and it's coming out above the vertebra. C1, C2, C3, C5, 6, 7, and then we go to the nerve below, C8, and then T1, T2, etc. And if you get a spinal cord injury, it's not completely nice slices. It's like standing like this, with your toes a little bit to the inside, your hands like this, more maybe a little like that, where as a man your crown jewels pushed to the back, and is measured. These are measured by key muscles to get an idea about injury, and these also with key muscles, and here it's with sensation. And this is the ASIA score. Well, if you look at the outcome of patients with different heights, then you see it's not randomly distributed. Well, first of all, maybe one of the students, do you have any idea why this is much lower than C4, C5, C6? Any idea?
Because of survivals or...
Yeah? Not a student. But yeah, indeed, if you have a C1, C2, C3 lesion and there's no immediately help to get your ventilation going, then you will just die. You will suffocate. So that's why there are not so many C1, C3, because the diaphragm is out of work, and yeah, without diaphragm you can't survive if you don't have artificial help. So then we have this group, and then it's much lower here, and then a peak here again, and a low there. Again, any idea? Yeah, one of the students, I hope, maybe. All right, you can.
Okay. No, the basic one is like the anatomy, the way how the connection happens. So if you look at the canal and how the spine is organized and mobility, then the largest range of movement is around C4, C6, yeah. And again the thoracic.
Yeah, exactly.
That's the reason that the injury is good.
Yeah. So here all the ribs protecting your back, and here that's almost all bone. This is a lot of bone, but in the middle you're vulnerable. And this is also an interesting group if you look at FES cycling, but I will come later to that. First, I have an example of someone with a C4 and using a FES bike. In this case, a stationary bike. questions. Actually, this is a C5. This is, I don't know why this reversed, but this is Johnny Williams. He was also our Cyberton athlete. He already used the Berkel bike for quite a while. What you can see is his hands are fixed. Over again. Ah, that's the video I asked you before. So you can see here, no hand function at all. He's moving his wheelchair with his chin. But look at his face. He's really puffing. And this guy normally doesn't have any exercise at all. So he's really pushing the pedals. So for him it makes a big difference. It's maybe not for the Cyberlong, but it's important to get people like him doing some exercise. I even have a C3, C4, and and there was a question about amount of training. Sometimes these high spinal injuries need some extra time to recover. So, for example, the C3, C4, if he cycles 3 times a week, he already noticed that his performance is less, he's not totally recovered compared to 2 times a week. But as someone with very low pulmonary function, not much ventilation capacity, so that's also something you have to keep in mind. These people are relatively weak, and you have to give them time to train and to see what is their limit of performance, how much training can they do. So don't be too strict, everyone gets the same training. That's the other guy, the C5. Johnny is in the room now. And there's just one vertebra lower. Which actually, well, he's quite good C5, to say. Now I hope. So, he needs help to get on the bike. That's clear, because his hand function is very, very limited. His hands are fixated to the hand pedals. He cycles partly with legs, partly with arms and legs, to go faster, to go uphill, etc. You can see it nicely. With the Cyberton was of course not, he fixed one hand and the other hand was used to just push buttons. He was able to push buttons, but he doesn't have any hand function, so he can't really grab something. In the final, he did even better. He really went for it, but there were cables from the cameras from the outside to the inner part of the track, and there's kind of bump, and he went over the bump, and at some point he just moved a little bit forward, and because he was not paraplegic, he could not use his arms to readjust himself. So that's also something for us. We also have a lower position. We will try that tomorrow to work with the bike with Johnny in a lower position. You didn't know that, by the way, just that you know now. There's something very important if you go above T6. There's autonomic dysreflexia. You have to keep that in mind. And you have to talk about everyone you use, every subject above T6, you have to talk about autonomic dysreflexia. Do you know what it is? Do you have it before? If you have any signs, just lower the stimulation. Don't go higher because you want to perform well or whatever. Don't go over a certain limit. Because almost any stimulation below the T6 can cause this. So pressure areas, anxiety, restricted floating, all these kind of stuff. But also electrical stimulation, if you have some well, you don't need sensation, but the sensation of the electrical stimulation can cause an autonomic dysreflexia. What will happen? Vasoconstriction below the level of injury, so pale, cool, no sweating. Vasodilatation above, so red head, heart rate goes down, sweating goes up in the head, headache, flushes. So if you see any signs, just ask, hey, do you feel well? Is everything okay? And you don't even have to stop everything right away. You can just go down with your electrical stimulation. The funny thing is, some of my customers use this on purpose. So some of the high injured have a very low blood pressure. I mean, 70 above 50. Something like that. It's very low. That's very, you can see the face being quite pale. And if they start cycling, sometimes they go on purpose a little bit to the level of autonomic dysreflexion. Then the blood pressure rises a bit, but they feel better. If they push 1 or 2 plus buttons more, then it will become a problem, because then the blood pressure will rise further and it can even become dangerous. There's another thing, implants and FES. And the interesting thing is, metal implants, so for example, if you have a broken leg, you can still use normal FES. So, I mean with normal FES, the FES we're all talking about, I will show you something else later, but with the short pulses, up till half a millisecond, to trigger the nerve, you can still use it. Bladder stimulated, no problem. Pacemakers, that could be a problem. It depends on the type of pacemaker. All the patients with a pacemaker have a card from the manufacturer. There's a number on it. You can call it and they can assist you. You can also, of course, talk to the physician and ask him, alright, is it okay if he's participating or not? But all the people with a pacemaker have a card from the manufacturer. Now if we go a little bit lower, then you get people with complete arm function. They can use their arms completely, but to improve cardiovascular fitness, you need 50% of maximum oxygen uptake. The mistake sometimes made is that if you have a disabled person, people do a test, for example, hand cycling, and say, alright, this is your 100% VO2 max. But that's not correct, because, and then they use this 50%. But this 50% is only if you use the big muscles, that's in our case the legs. If you use the big muscles, then you can measure really the maximum oxygen uptake. If you only use the arms, you will be lower. If you have a higher spinal injury, it will be even lower than that. So don't take that as 100%. Try to estimate what 100% would be, should be, if you want to really have an optimum training effect. If people are paraplegic and they have full arm function, they can do, of course, much more sport, more training. But still, compare the exercise of your arms and the exercise of your legs. If you do 10 minutes of running, that's such a big deal. But 1 minute of push-ups is very, very hard. I don't know if anyone in this room is able to do really nicely 1 minute of push-ups. And that's with 2 arms, half the body weight. With running, every time you jump from one leg to the other leg, and the landing is with 3 times your own body weight. So that's the amount of force your legs are able to handle. And you can see that because if you look at people that are doing wheelchair sports, like in this case hand cycling, you can see a few things, and it's one of the things is that, okay, these guys here come from very warm countries and they almost have no clothes on. She has a lot of clothes. That's a sign there's not much action uptake, not much what's the name? Energy expenditure, because from, well, the efficiency is something like 25%, and the other 75% will be heat, warmth, which you have to get rid of, so they don't have much clothes on. She has a lot of clothes on. And there's another thing, they don't have much energy reserves. She has a lot of energy reserves still in her body. There's also a bad sign. And if you look closely to the legs, or to the faces, you see very relaxed faces. Of course, because they need all the energy for the legs, for the running. If you look at her, I don't know if you sometimes come in the gym and some of the bench presses, you quite often have to tell them, keep breathing, keep breathing. She's doing a power exercise. She's training her arms. That's the limited factor, the arms, not the cardiovascular system. And that's why this was the world champion hand cycling. That's why this guy has such incredible arms. A marathon runner doesn't have incredible legs, but he has an incredible cardiovascular system. This guy has incredible arms and a quite normal cardiovascular system. And now something interesting. Some of you were at the IFES, and Glenn Davis, Professor Davis, said, the study, this hand study in Amsterdam, showed there was no effect of hand cycling or hybrid cycling, so arms and FES legs together, compared to hand cycling. There's no additional effect for, of course, for muscle mass and so, but he meant for fitness, so for maximum oxygen uptake. Well, the interesting thing is, if you look at the data, they wanted to do 2 groups of 20. They did a power analysis, sample size calculation, and we needed at least 2 groups of 20 people. But they had to be at least 10 years post-injury. They should be adult when they got the spinal injury, so, and they were not allowed to be older than 65 years. So at the end, they have to be between 28 and 65 years, at least 10 years post-injury, and they have to come 32 times to the rehabilitation center. I don't know if you did ever try to recruit patients, but that was very, very difficult. So at the end, we had much smaller groups. 9 in the Berkelmans group, hybrid, and 10 at the Handbike group. They trained 16 weeks, 2 times a week, 30 minutes. And these are the results. They're in the book. I've got it with me. Peak power output, hand cycling 50 to 52.5. Here, 39.5, 45. And these results resulted, let's go here, you can see it even better. The improvement was 3.6% for the power output with hand cycling, 3.5% for oxygen uptake, and in the hybrid group, this hand cycling and FES cycling of the legs, 15% of the power output, 12% of the oxygen uptake. So that's almost 4 times as high with the hybrid group than with the Handbike group. I think at the end it will be a little bit less, but at least it's a little bit strange that people then say there's no effect. But that's because they only look at the p-values. But the p-values tell you, alright, how likely, what's the probability, the speed probability, that the people that responded well were just by instant in one group. So if you have low numbers, you get a higher p-value. So the p-value was 0.11 and 0.14. So there's a clinical effect, but not a statistical effect. But the statistical effect is also because you should have had more people, and then, yeah. So it's more a pilot study. We want to do a real RCT, but it was more a pilot study. And as a pilot study, it was quite successful. But that's quite irritating if you're at the IFS, and then the other guy just says, well, but you're from Berkelmans, so just the wannabe results, but these are not wannabe results. These are the real results that were in the study. Another example of someone cycling but with a lower, with a T4, paraplegic, and you will see the difference. Yeah. So he just connects to his own wheelchair, and he can cycle from his wheelchair. He also uses shorts. So we have adhesive electrodes. Sometimes you use an adhesive electrode, but you can also use shorts. And he can put his legs himself in the orthosis. And he can do all this work himself. And that's of course a big difference. If you have a high spinal injury, you have no hand function, that will be impossible. But in general, they also have more help around. So you can train at home, you can train outside also, because it has to be fun to do. That's a very important thing. You want to have people, if you only have a stationary bike, it's of course less fun to do. Now some other factor. This is how it normally works with us. We have a nice motor neuron here waiting for a signal from the brain. It's a little bit complicated, but at the end there's a motor neuron, and if it's excited, it will exercise the axon, and it goes to several fibers. So one implementation of this is that I can sometimes customers say, I can go as low as 30% with my electrical stimulation. Like a goal to go lower with your electrical stimulation. But the thing is with electrical stimulation compared to healthy persons, is that with electrical stimulation, every time you use the same motor units. So if if you use the same electrode, you will stimulate the same motor units. So if you want to have as maximum training effect on the muscle, you have to go higher with your training intensity, because you go deeper. So you start stimulating, for example, 20% of the muscle, these motor units fatigue, then you go up with the stimulation and you go deeper into the muscle. Deeper, deeper, deeper. In principle, till we normally use 150 milliamps. Not everyone goes to 150 milliamps, it's also depending on the person. So, for example, if someone has a lot of fat around his legs, he will probably, and no complete T8, he will probably go to 150 milliamps. But if someone has very tiny legs and not much fat around it, then if you go higher, you get crossover, because the current is getting deeper and deeper into the muscle, and at some point you stimulate the quadriceps, but you also stimulate at the same time the hamstring. Or you stimulate the hamstring, you will at the same time stimulate the quadriceps. So you also have to look at that person, not only what you can tolerate, but also when is the stimulation going, works against him, so at which level. But for training purposes, for physiological reason, you want to have as high current stimulation as possible. This is the normal way of spinal injuries. All the people you saw before are spinal injuries above the lowest motor neurons. And if you look at an intact spinal cord, well, the muscle of someone with an intact spinal cord, I have to say, so this is the able-bodied muscle, and this is someone with an upper motor neuron lesion, so a lesion above the lowest motor neuron, after 20 years. And just looks the same, only badly trained. Badly trained. And there's a second thing, there's a phase shift in fibers. So that means, simply said, type 1, slow fiber, marathon fibers, type 2, fast twitch fibers. If you get a spinal injury, the percentage and surface of fast twitch fibers will increase. So the total amount of muscle will decrease, but the slow twitch fiber will decrease much quicker. And the spasm can still get your type 2 fibers at a certain level. So it's more like a crocodile muscle. This will happen in a couple of years' time. So 2-3 years' time, you see this phase shift. If you start training, you can shift it back. Of course, that doesn't happen in a month or 2 months. It also takes a couple of years. So that means that if you have for a longer time a spinal injury, you're still able to be a candidate for fast cycling and even the cyberlong. It depends on, maybe you need to train a little bit longer, or a couple of years, before you get the same fiber shift as someone who is more recently injured, but they're still perfectly able to be a participant or to be a pilot. And a very important thing are the spasms. There's a lot of things we can say about spasms, but let's put it this way. If you normally tap with a hammer to the knee, there will be an automatic reaction, there's a sensory input, and there's a motor output, and your knee will stretch. You could see the spasm as a kind of exaggerated stretch reflex. There's no connection to the brains anymore. The brains normally inhibit this kind of spasm reactions. If there's no control from the brains anymore, you can get quite severe spasms. One of the strange things I learned on the IFIS was that as a male participant, if you're paraplegic and you have a lot of spasm, it's possible with the vibrations to get an ejaculation, and the ejaculation gives the person a much lower, will relax the muscle, so inhibit this part, and then you get much less spasm. So I didn't know that. I also don't know if it would work with cramp, so if a soccer player would get a cramp, then maybe they should help him with pushing his foot. But some very good looking nurse should come very quickly to help him relax and
the game would be more interesting.
Yeah, the game would be much more interesting, exactly, to inhibit this part again. So there's a lot of things with the spasm. So first of all, the spasm is a very good sign if you want to do FES cycling, because the motor unit is still working. So that's one of the first questions I ask if someone has a thoracic injury. Do you have spasms? Yes. Okay. Does it really, do you see a muscle contract? It's also training for the muscle. So I noticed that if you have someone who has a lot of spasm, the first time he cycles with FES, his performance is much of the time much better. So it can be annoying and disabling, a spasm. It can even be hammering the start of the cycle. If you start cycling, then spasms can stop the motion. But if you get the motion going, then the legs will relax, and the muscles are much better trained if someone has had a lot of spasm before. So If it doesn't prevent fast cycling, and most of the time it doesn't, it will get less in a few minutes. And the nice thing, often it stays away for a couple of days. So quite a lot of my patients use the FES cycling to control their spasms. Long-term FES cycling affects most of the time positive, so most of the time. Most of the time you get less spasms. But also the muscle is stronger, so if you get a spasm, it can be a little bit stronger. And so for 90% it's positive, and sometimes also for we don't know, it gets worse. It can also be that there's a sign of something else. It can also be a sign of, if over time the spasm increase, then it can also be a sign of something else. It can be related to the cycling, so maybe overtraining, maybe there's a knee problem, maybe there's something else. It can also be just a bladder infection, or but so it's very hard to predict the spasms. Sometimes they're your friends, sometimes they aren't. And there's also an important thing to know. Spasm medication in FES. Baclofen has no direct effect on the spasm. On the FES cycling. So most of the spinal injury, or almost most of the spinal injury used baclofen, and that's not a problem if you want to go FES cycling with them. But if you use dantrolene or famotidine for aminopyridine, then it has a negative effect. It has a negative effect because the medication works on a different level of this loop, this sensory to motor neuron loop.
What happens?
Yeah, so dantrolene has an effect on the calcium output of the T-tubule. So that's really in the muscle. So that's why also if you use FES and people use dantrolene, it will the effect of the contraction will be less.
No point.
Yeah. Same with famotidine. It works on another level, but same if you use stimulation, less force coming out. So you can ask, or can you talk to your physician, can you use other medication, for example, baclofen? Well, now there's another interesting thing in the spine. These motor neurons are up till here. These are all axons. Well, why do we care? If you get to the lower spinal injury, the lumbar, you get a situation where the injury is below this motor neuron. So this means that there's only a peripheral axon connected to the fibers. And this part will just die. This will go away. So this one is still getting instructions, but nothing happening here. And if there's no motor neuron on the fibers, you will have no spasm at all, and the decrease of muscle mass will be much stronger, and also the fibers themselves. Again, you have these are the upper motor neuron lesion, and this is a low motor neuron lesion. So this, after 1 year, it still looks quite okay, but after 4 years, you see a tremendous decrease in the muscle itself. So, yeah, this type of muscle can be now stimulated directly with a large device made by Schufried in Austria. It's from a European project, and there are incredible differences. So what we normal FES uses 0.2 to 0.5 milliseconds of pulse width. With low motor neuron lesion, you don't have a nerve which you can stimulate, so you have to stimulate the muscle directly, and that's 5 is even very short, 100 milliseconds. 100 milliseconds. So that's 200 times more, longer pulse, but also twice the amount of current. So 200 times this, twice this is a charge of 400 times the normal charge you would give to the nerve to contract. So that's how important the nerve is. With FES cycling you have relatively quickly results, here you have slow results. And you have to train more. We don't know exactly how much, but most of the studies do 5 times a week or something like that. And mental implants are not a contraindication. With these kind of pulses they are. So these charges are so big, they could theoretically influence the metal implants. So again, very small legs. And if you look at an example, T6 was in this case, again he's a paraplegic, so he can do all the work himself. This is in the UK. The other guy is just holding his seat. Because there were no wheels on it. But now look at his legs. And this is a guy with almost a very slim guy, not much fat. But look at the amount of muscle has become just with electrostimulation. And he fatigues much quicker than, for example, Johnny. So then he just uses his arms so he can continue the stimulation. So now we get a customer and he's T8 and he's flaccid. How is that possible? How can be a T8 be flaccid?
Peripheral dominance?
Sorry.
Peripheral dominance of a nerve?
Yeah. Well,
It's likely a combined injury.
that's also a possibility, but that's rarely, I never encounter that. In theory, it's possible to have a T8 and a T12 or an L1. If you have a very terrible car accident and you break your spine at 2 levels, that's possible. It's
swelling can contribute to that.
yeah, swelling. But what's more likely is that someone didn't have a traumatic spinal injury, but a ischemic. So there's a blood vessel which just erupted or was blocked, an infarct, and then you have a whole part is just died, was without blood perfusion. So that's another thing. How did you get your spinal injury? And then if I discover it's something like an infarct, then you know, aha, okay. Because the T8 from the Asia score just checks everything above and say, all right, oh, this is still working, this not, so you're a T8. But doesn't tell you anything about what's below. So be aware, not just think, oh, he's a T8, so you can use FES cycling. And a good question for it is, did you ever have spasm? And if they say yes, I made a mistake also before, if they say yes, you have to ask the second question. Did you really see your muscle contract? Because sometimes you get the answer, no, but I feel it. But that's not a spasm. So be aware that your idea of a spasm is maybe not the same idea as the patient has what a spasm is. So ask, really, did you see the muscle contract? Did you see your leg move or something? Very important thing. So if you look to the scale, above T6, lower heart rate. So also I saw some training schedules, and then you just use 220 minus your age and that kind of stuff. That doesn't work. That doesn't work if you have a high spinal injury. Your heart rate is probably much lower. So check what's the real maximum heart rate. Keep in mind lower heart rate. Also, by the way, lower pulmonary ventilation capacity.
I just asked, but how do you know how
How much to push? Yeah, that's a good question. So, really work with the patient. If he starts cycling, then first of all, how is he reacting? Is he still cheerful, or is he getting quiet, is getting pale, is there something going? So watch, don't just first time put the stimulator on and go away, just watching. How is he doing? And what I like is let the person himself handle the intensity. I don't like it when a computer is telling how much intensity the person is going to use, or with all respect, some student. I want to be the person himself in charge. Look to his legs, talk to the person, and afterwards, if he does it the second time, the third time, did he completely recover? It's also important. And then you can go a little bit higher, and then, but just keep in contact, because it's quite individual how people react. So in the intensity, don't be too shy to go up with the intensity, because some people can cycle perfectly with 30%, and if they come above 60%, it's already too high for them, because the muscles start to do, you have co-contraction, or they get signs of autonomic dysreflexia. But some other people, they can go to 100% and almost have no contraction. So the differences are extremely big. So always just look, and don't be afraid to go higher with electrostimulation. It's not a very, it's not, you won't risk something, well, it's the reaction is so differently from person to person. So really look at it. And here you have to have alert of Flaccid. Does this really, person is really able to get the normal stimulation and get normal contractions. Now the autonomy and the fast cycling. We use a very simple setup. Gluteal, hamstring, quadriceps. Why? Ken is completely right, the most power comes from the quadriceps. But for me it's also important that not for training for the cyclotron, but for people at home to get benefits from it, to have good, nice gluteal muscle and a nice hamstring, because they're sitting on it. These are the very most important muscles for your weight distribution. And also, the more muscle I activate, the bigger the physiological effect is. Why 2 on the quadriceps and not more? Because of the work they have to do to put the electrodes on, and ideally I would like to have more. But I also want to make it as practical as possible on one side. And on the other side for the cyclotron, the UK team was in the UK and I'm in the Netherlands, so it's very difficult to do experiments, so I expect from the group from Amsterdam to have some nice work doing with stimulation of the quadriceps with multiple electrodes. So this is not ideal, but most practical. And Johnny did very well, so I'm still very satisfied about the end result. If you look more detailed to the anatomy, with the quadriceps, of course, there's 4 parts, and the rectus femoris, it's a Latin, so you can't pronounce it wrongly actually. It's over the hip and over the knee, so it's bilateral. In principle, you're stretching your knee in another phase, then you're bending your hip. But with the quadriceps is overwhelming in stretching the knee, and just a relatively small part bending the hip. So for FES cycling, that doesn't bother me too much. It doesn't affect the FES cycling too much. This part over the hip. If I'm going to the hamstring, that's another thing. That's much more complicated. There's 3 muscles, the biceps femoris, and this one is going over the knee and over the hip, but this one is only over the knee. But this is biarticular, and this is much bigger. Semimembranosus, both biarticular, semitendinosus, biarticular. And now you get the following problem. So the hamstring is standing, stretching the hip, and bending the knee. But with cycling, I'm bending my knee, and I'm stretching my hip. So there's a completely different phase. So that's also why, some other people, well, Ken said, the hamstring that didn't work for Julien. I noticed that there's a tremendous difference between patients. Some use it as a hip extender and some as a knee bender. It's depending on what's dominant. And what's dominant is depending on the anatomy of that person and the position he's sitting in. So is he sitting more upright? Is he more laying down, more recumbent? Is he stretching his legs completely? Is it more bended? So these are things that are very important. It also means that if you change the position, your optimal stimulation will change. And the firing at the right angles is the most important thing for FES cycling. More important than all the other factors, the rolling resistance, the spatial distribution, all the other things. If you don't fire at the right time, it's quite hard to get power out, but it's very easy to wreck the cycling motion. If you stimulate the muscle at the wrong moment, it will just eccentric. A muscle is much stronger than concentric, so it's easier to ruin the cycling than to increase the power output. Where I have with quadriceps a difference of 30%, 30 degrees, sorry, in starting or stopping angles. Gluteal the same. With this, I have differences of 170 degrees from person to person. So that's a completely different position of stimulation, moment of stimulation. Gluteal muscle, quite hard to get a nice power output. It's difficult but important to stimulate because for sitting, for preventing pressure sores. Questions?